lie to me? Come on, give a befitting reply that it belongs to the originator from where it started. Samit, please.
Yeah, thank you very much, Dr. Mohan, Brij Mohan, and I actually have just 2 slides because I knew where this debate would go. It was completely misread. The debate was, have we lost it to a cardiologist? And the cardiologist thought that the we means it's a diabetologist. And he has shown OSA, he has shown renal benefits. I don't know when OSA, renal benefits, and other benefits have become the cardiologist domain. This was really news to me, that from tomorrow I will send all my nephrology patients with microalbuminuria to my cardiologist, all my OSAs to my cardiologist friends, and all non-cardiologic benefits that he has shown in his slides, everything will be referred to cardiologists from tomorrow. And I really thank him for that, because he just said EMPARAGE was published and it was studied by all cardiologists, right? It was published in NEJM, which is one of the premier general medicine journal. So now I will write an editorial to NEJM. Either you allow cardiologists to write in a general medicine journal, or from tomorrow, you only allow physicians to write in your journal. Credence was the trial which was published in American Journal of Nephrology. So from tomorrow, we will not have any microalbuminuria related articles which can be presented in any nephrology journals. I'm going to write an editorial tomorrow to the editor of the American Journal of Nephrology. And he just stole the whole thing. I do not know what to say from now onwards, that the mechanism by which you have your cardiac benefits, renal benefits are unknown. Yes, absolutely true. The only thing known about SGLT2 is that in a diabetic patient, there is a 3 times upregulation of the SGLT2 mRNA, resulting in development of increased glucose absorption. The only thing known. So that is the only way it acts. The only thing you know in mechanism is reduction of blood glucose. In mechanism, you do not know how you reduces the heart failure, how it helps heart failure. They are postulates after postulates, and none of them are cardiologic, by the way. Ketone is not the cardiologist domain, it's a metabolism domain. And then you have the hematocrit, and sometimes you have the uric acid. I'm sorry, again, cardiologists want to enter that area, but again, these are maybe a rheumatologist domain, as he rightly pointed out, of HCQS. So, for me, it is something that we have discovered way back from the apple tree of the apple bug. It's a very old story, and it was seen that when it was given to goats and sheep, they used to urinate a lot. That is how the whole story came. And once we have this molecule and all the pleiotropic benefits coming in, different specialties are now joining in order to claim their molecule. I can understand in the last 20 years from molecular perspective. After ACRB, the cardiologists have nothing to boast of, and now they have the ARNI to boast of, which you cannot prescribe to half of your patients because of its cost and the side effects. So you have to enter our domain. I see this is something which I don't do. I am repeating your slide. You have exactly shown what I wanted to show. We need more physicians who are being killed today, family practitioners who are taken off the radar. And that is resulting in this is what is happening. A cardiologist is claiming their stake on statins, ACRB. Come on. Statins were initially in market to reduce cholesterol. Then the pleiotropic benefits were found. And it not only reduces cardiovascular benefits, it has benefits on stroke. Well, again, I'll refer all my stroke patients tomorrow to you, don't worry, because I hope that is also a cardiovascular area. I'll not involve my neurologist. If there is a blood pressure issue, because ACRB also have pleiotropic benefits, so before writing any blood pressure benefit, I will refer all my patients to a cardiologist tomorrow. Antiplatelets, well, I will not write antiplatelets from tomorrow because they also reduce cardiovascular events. So I'll send all my patients to you. Digoxin, I will not even try to touch, anymore from tomorrow, even if I have a scope. And SGLT2 and GLP-1, don't worry, I will not write at all. As it is, cardiologists have started writing it even without consulting us nowadays, taking off metformin, doing a wonderful job, and sending us with an A1C of 12 and 13. We're pretty happy with that. You can continue doing that. Now, one area I can never enter is PPM and stents and ICT. I think this is the only area the cardiologists are left with today. The true cardiology today is an interventional cardiology. The rest is they're just doing the physician's job. And the physicians might be doing a better job than you when it comes to such drugs, because we are not like touching the elephant. We're actually looking at the elephant. And the rest of them are actually behaving like the elephant, just the reverse of what you have showed us. This is my last slide I'll be showing you. I said I've come only with 3 slides because I knew you will be talking about the pleiotropic benefits and doing my job. So I don't have much to say. Now, benefits of SGLT2. You have shown like a bird's eye view concentrating on a few of the articles, including mine. Thank God. I was thinking, who is going to show my article? Where am I going to fit my articles? You have done it for me. You have shown 3 of my articles. I'm really grateful to you on that. But here I'll be showing none of my articles. If you see, these were the ones which were studied in phase 2, phase 3 trials and found extensive in 14, in each of the SGLT2, 14 to 16, phase 3 randomized controlled trials to reduce HbA1c, weight, systolic blood pressure. And all the benefits you have shown from the cardiac perspective were irrespective of significant benefits in HbA1c, weight, and systolic blood pressure. So the statement that you made, there is a significant, robust reduction in weight, robust reduction in systolic blood pressure. No, sir, it was not there. We showed one study where there was a 5 millimeters of mercury reduction in systolic blood pressure. The mean reduction across all studies is a mere 2 to 2.5 millimeters of mercury. The weight reduction varies between 0.5 kgs to a maximum of 2.5 kilograms, nothing more than that. None of them make either cosmetic or cardiovascular benefit. And that is what the benefit of the drug comes from, that it is irrespective of those metabolic benefits. So if it's so, then you're cutting your own argument by saying that there was significant reduction in blood pressure in others, which could have then contributed to the cardiovascular benefit. So then again, it doesn't become a cardiovascular drug, it becomes an antihypertensive. So you see, this is how you're cutting your own argument. Now, I'll give it to you that there are cardiovascular benefits in MACE reduction with some of them like canagliflozin, with CV death reduction, remember it's only with empagliflozin. It's a composite of the CV death and HHA for heart failure with dapagliflozin. Fair enough, we have seen that. But there is an asterisk which I've given there, and this asterisk applies to you. This is what differentiates me, a physician, from you, a cardiologist, which is SGLT2 cannot be used in any acute patient. I refer my acute cardiac patients to you who have to be taken off an SGLT2. So you see, you are deprived of the benefits of SGLT2 as a cardiologist. But I can always give the benefit of SGLT2 to my patients because I'm not dealing with an acute cardiac case. You must be at least 3 months post CABG or PTCA to even start this molecule. You have to be completely stabilized. Now, I know you'll say, what about heart failure with reduced ejection fraction? Well, stabilized patient, not decompensated patients. And these are all the patients we physicians treat anyway. We don't even have to refer to a cardiologist if we do a good job. If they fail on a statin, if they fail on a mineralocorticoid receptor antagonist, if they fail on diuretics, if they fail on SGLT2, then we send maybe for an ICD, which definitely I cannot do. That is your area. Albuminuria, macroalbuminuria, EGFR decline. You showed it rightly. Thank you very much. But this is the domain of us. We prevent it. And if things go wrong, we send it to a nephrologist, not to a cardiologist. Come on. At least you don't start pulling the extraneous benefits of a guy going into dialysis and developing a heart failure. I mean, if you want to draw those conclusions, there is no end to it. Even a retinopathy, according to some article, is a high risk for cardiovascular disease. And hepatic, well, I don't think you want to enter this area at all, right? And it's the inflammatory markers, SGOT, SGPT, GGT, liver fat, which is the MRI, PDFF, or visceral adipose tissue reduction. Fantastic data has come now very recently that they can even do that. Now, if I add these benefits, these are just a few sample benefits. I've not included a few more that you have given. Otherwise, your percentage will be jeopardized even more, like OSA and others. So there are 11 benefits. Even if I give 3 to you, what is the percentage? 27.73. Okay. Of 27.73, if I take the acute cases and take the chronic, 10% of that, 2.7. Your domain is 2.7 of all the benefits of all the SGLT2 inhibitors. Now, in spite of this, if you want to claim that this is a cardiologist molecule, then I have nothing else to say, except I'll change my practice randomly from tomorrow if I lose this debate. Every single patient with fatty liver, every single patient with OSA, every single patient with microalbuminuria and macroalbuminuria, I will refer to you. I'll ask my patients to buy a ticket and flight and go and visit you. Definitely, don't worry. I can see the debate in that point at that point in time. And this is from the great William James Mayo, given one well-trained physician of the highest type, and he will do better work for 1,000 people than 10 specialists. And I completely think this is where our whole system is going wrong by going the specialist way. We need to go more towards the physician way. And there has to be a collaboration with the specialist, an interactive collaboration where those minuscule cases, the tip of the iceberg goes to you. The rest has to be managed by us. Thank you very much.
Thank you, sir. With this, we'll just take a small poll and let's see how the audience have taken the debate, and we'll just get a poll on to have we lost the SGLT2 to cardiologists. All those supporting Dr. Kamal Sharma sir.
Voting is not going to benefit me.
You
I
have
know
to
that
give
for sure.
2 minutes
Nobody-
rebuttal also.
No
Dr.
diabetologist will vote for a cardiologist at least when you speak like this.
How many cardiologists are there in the audience?
Barring
Right.
Dr. Dani and me, I don't think there are any cardiologists in the
No,
audience.
you two are in a panelist, but others are not there as a delegate.
I don't mind losing because my name is misspelled. So anyway, someone else is going to lose.
Dr. Samir Dani, you can ask both of them to have 1 minute rebuttal.
Yeah, I was wondering that why not have a rebuttal? We have
Yes.
little time. So Kamal, you can, you can do it in
Yeah.
30, 40
So
seconds.
thank you,
and-
Dr. Ghosal, for referring all your patients from Kolkata to cardiologists for treating their blood pressure. I'll be happy to treat their diabetes also, because I also did my MD medicine training and I used to treat a lot of diabetes in MD medicine. The problem is not that. You think all cardiologists are interventional cardiologists. That is not true. All physicians are definitely cardiologists. All physicians are cardiologists. Why? The CSI membership, if you see, only 30% are interventional cardiologists, 70% are physicians. Why you are depriving physicians to be physician practicing cardiologists? Just the way every physician is a diabetologist, every physician is also cardiologist. Don't deprive them of being cardiologists. So if you're talking intervention cardiologists, yes, we do all the 3 intervention. But treating diabetes, every physician who calls himself as physician and diabetologist is equally, or cardiologist and diabetologist is equally qualified and important to treat this as a cardiac molecule and treat their diabetes as a qualified cardiologist. That is my per se. Second thing, you accepted that acute cases. Sir, there are 3 papers, one of my own. I thought, sir, I gave you a lot of respect by searching your paper. You could have shown a couple of papers of mine. I was pleading for that. But there is another paper that we are writing of 500 plus paper of patients in acute settings that we have treated with an SGLT2. And Dr. Bansi used to come and see for those 3 euglycemic ketosis, the incidence of which was same as that you find in Emparec. Number 4, you did not touch upon the apple thing. I said, you just said, okay, apple maybe tha, so is apple the diabetic fruit? No, it is not. Apple belongs to everybody, just like God is everyone's. Apple belongs to everybody. What about, you talk about nephrology and SGLT2 upregulation. And SGLT2 upregulation, I completely give it to you. Yes, it is upregulated. But then in diabetes, creatinine also upregulated. The EGFR also falls. Do you say that it belongs to diabetology? No, then it has to go to nephrologist. Look at the gentlemen, the nephrologists are. They don't claim it. But if you think that nephrologists are going to let it go to diabetologists, cardiologists are going to sit silently, that is not going to happen. We are India, China. We will not let China take away the Galwan Valley. We are going to get back that very strongly, because it always belonged to us. Galwan was basically a Kashmiri guy. So it has to come to us. And your own paper, at least the conclusion should have been very clear. It says it might prevent diabetes complication, but you definitely wrote it does prevent cardiovascular benefit. You yourself in your paper have said it has cardiovascular benefit. It might prevent diabetic complications. That is from the statement from the paper I've copied and pasted. I never said Emparec was published, not in any JM. I said it was first late breaking. It broke first in the conference of a cardiology meeting. Then the publication to please every diabetologist was done in NEGM. It was broken as a conference, late breaking trial in a cardiology conference, which I've shown the slides. So
Okay.
I did not get any rebuttal on the apple, the mechanism of action, and some blood pressure reduction. Dr. Ghosal, blood pressure reduction is now almost touching double-digit reduction. There is a latest paper also which talks about 9 systolic. Mean is 5. There is a paper from SGLT2. There is a paper, even in this paper that I've shared here, it shows that in the full dose, the mean reduction compared to the placebo for the systolic pressure is in the range of 9 millimeters of mercury. And there are some trials now which you can go through. Even people from remogliflozin are not talking about double-digit reduction. You can take it with a pinch of salt, and I'm not talking as an argument. But Emparec data is clearly now, with the meta-analysis and the slides that I showed, shows that the blood pressure reduction is almost 9. Even if it is not 9, if it is 3 millimeters of mercury, let's me agree to your argument. In Ascot Bepla trial, 3 millimeters of mercury reduction of mean difference resulted in a result in favor of that arm, which resulted in outcome difference. If 3 millimeters in Ascot-Vapla could reduce the CV mortality by primarily an antihypertensive design, why would you not consider this 3 millimeters, which you are anyway accepting, as an action which can reduce the CV events? That's my argument. I think 1 minute is too little for me, but I could have gone on.
दिल पे ले लिया कार्डियोलॉजिस्ट ने दिल पे ले लिया argument Samit Ghosal ka. Let it not be like that. Samit, you want to say something?
Yeah, like my 3 slides, I have 2 statements. One, thank you very much. 70% of your CSI members are MD physicians. So you made my point. And the second is the millimeter of mercury of the systolic blood pressure. Well, none of in the benefits trials were non-inferiority trials. So you have done equally good job in the other arms, and without any difference in BP or anything, you showed the benefits. Now, if you come and start claiming that those benefits can be derived by reducing in blood pressure, then we have to nullify all those outcome trials and start doing a new trial by showing a reduction in BP and then nullifying that effect and showing that it is because of the drug and not because of BP. So you're actually nullifying all the effects and all the cardiac benefits you have just mentioned just now by that one statement of 8 or 9 millimeters of mercury. So you have to make up your mind. Either you go with the molecule and take it as in your domain, or you want to look at those metabolic benefits which we are giving anyways to a patient. Then the molecule remains with us anyways because the benefits is gone because it's because of blood pressure reduction. So you have to make up your mind.
Okay, I think we can.
Dr. Bansi, in the poll, you should include a physician also. Is it domain of cardiology, domain of diabetologist, or
No,
domain
we
of...
are not doing any. It is actually patient belongs to both. Whether it's we are all patient centric. It is not like that who is treating it. And thanks to Dr. Kamal and Samit. And now we have the next debate. So you can invite both the speakers. They are there.
Thank you, everyone. Thank you.
Thank you.
Minutes. And then